our audience, and it gives me great pleasure to welcome you to CRM 360 webinar. My name is Abdulraof Almahfouz. I'm consultant endocrinologist from Riyadh, Saudi Arabia, and section head endocrinology in King Faisal Specialist Hospital. We have an eminent speakers tonight coming to us from UK and from Germany. And our audience comes from across the region. So without further ado, I'd like to welcome Professor Michael Bohm, who's a cardiologist, and Professor Mark Petrie, who's also a cardiologist. So as you can see, we're all joined here because we have something in common, endocrinology and cardiology, and also we'll have renal at some stage and liver. So these systems are interconnected, and to take us through this pleasant and connection, Professor Michael Bohm, who's Professor of Cardiology and Internal Medicine and a member of the Heart Failure Association of the European Association for Cardiology, will talk to us about the cardio-renal-metabolic system interconnectivity and its relationship to diseases in those organs. So without further ado, Professor Michael Bohm, the screen is yours.
So thank you very much, Dr. Abdulraof. First of all, I would like to thank you for the invitation to talk to you. And I will talk about these complex titles, the interconnectivity between the cardio-renal-metabolic system and also, of course, the intervention to improve outcomes in the system. So these are my disclosures. I would like to make the 5 points which are depicted here. I will talk about comorbidities and outcomes in heart failure, a very brief mentioning of the new guidelines in heart failure. I will then discuss the role of CKD and the interaction with the heart failure syndrome, also about the impact of diabetes and CKD in developing heart failure. And then I talk also a little bit about acute intervention, cardio-renal, and then heart and kidney protection. And at the end, I will try to provide you a concept of all of this. So cardiometabolic comorbidities and outcomes in heart failure. So this is the current guidelines, just to remember you that we start, and this is the first listing. This is a very nice picture recently published on the guidelines. It's not the original one. You can see that we start with these foundational therapies, all reducing cardiovascular death and heart failure hospitalization. They should be initiated early. They should be up-titrated early, and they should be started in the hospital. And that is as fast as possible and given as high as possible. This has been shown by the STRONG-HF study published last year. So this is the baseline of everything of it. It comes along with decongestion and lifestyle modification. They all have a class 1 recommendation. Thereafter, one goes into subgroups in patients who have a high likelihood of suffer from sudden cardiac deaths, or people with a broad QRS complex. They give a CRT or ICD or the combination of both. We have hydralazine nitrates for Afro-Americans and people with high heart rate, potentially people with poor rate control in atrial fibrillation. And maybe there are new data, will be new data at the end of this year showing a new role of digoxin. We are waiting this eagerly. And finally, vericiguat, which is applied when patients are repetitively decompensating. So this is the second step. And then finally, we have to treat comorbidities. And that is mainly what we are talking about. And this is diabetes, of course, comorbidities of kidney. We'll come deeper into that. And of course, sleep apnea and iron deficiency and others. So this is the overall concept in heart failure. But there is no such thing than stable heart failure. So all of these interventions should be done according to the tolerability of these interventions in specific patients as swiftly as possible. So what is the role of diabetes? And I brought this slide to show you that it is true what we talk to our students, that we indeed have in diabetes a strong association to cardiovascular risk factors and in particular to vascular risk factors. So what you can see, the control here is people who have no risk factors, and you can see people with 1 risk factor, 2, 3, 4, and 5 risk factors. They have an increased risk. And the earlier these risk factors are imposed on the body, the higher the risk is. That means 5 risk factors amounts the risk of cardiovascular death about 5-fold, and the risk of stroke and myocardial infarction about 8-fold. Now, when these risk factors are controlled, and this is meant by this is a control, no risk factor, and these are all controlled risk factors, and this is the vascular outcome of stroke, you can see that there is nothing significant anymore. So the control of vascular risk factors reduce the risk of vascular outcomes. On the other hand, you can see heart failure outcomes are, if all risk factors are controlled, are still maintained. There is a 2.4-fold increase of heart failure risk in patients, even though all risk factors are controlled. And this indicates that this endpoint and the vascular risk factors and diabetes are acting in a different way. You can see also that there is, with uncontrolled risk factor, of course, the heart failure risk is markedly elevated to a factor of 11 if there are 5 risk factors starting to have their action quite early at the age of below 55. That indicates that in heart failure, in diabetes, there is always, despite any control of risk factors, a residual risk to get a heart failure syndrome later. Now, principally, we know that. We all talk more about vascular endpoints in diabetes, but you can see this is the first mentioning of heart failure in diabetes. This is from 1974. This is a Framingham study, but you can see that individuals who have diabetes, and when they are quite young, they have an increased risk, which is about 2-fold. But women with diabetes, maybe this comes along with heart failure and preserved ejection fraction, have a 5-fold increase of heart failure risk. And this was then called already at that point of time. There is a cardiomyopathy, a specific form, diabetic cardiomyopathy associated with long-standing diabetes. Now, we know that, of course, CKD, which is the other risk factor, is indeed moving from place 8 to place 7 in patients from 2009 to 2019 as a cause of death. Yeah, this is from Global Burden of Disease in 2020. So there is, of course, an increase in CKD risk, which is, of course, also associated with diabetes. And you can see that CKD, and here is EGFR. When EGFR gets lower, there is a marked increase in coronary event risk, and there is a marked increase in stroke risk. So what about heart failure? You can see the same thing. It is an increase of heart failure risk. On the right-hand side, there is a depiction, and I will come later to this in a minute, of albuminuria. And you can see also albuminuria is closely associated to increased risk of these vascular events, but also heart failure. So there is an interaction between diabetes and heart failure, diabetes and chronic kidney disease, and CKD and heart failure risk, which can be, of course, seen at the function of the kidney, but also of early damage to the filter, which can be easily looked at by looking at albumin excretion, which, by the way, as shown here, should also be done by a cardiologist. And this does not start at a high-grade albuminuria or high-grade proteinuria. You can see there is a 1.5 increase of heart failure risk also at albumin creatinine ratios of 30 milligrams per gram of creatinine, indicating that this is very sensitive to predict the heart failure risk. So please, also cardiologists should look into the urine. So this have you seen before, the CKD increase of risk. But what we discussed a minute ago is that it is even worse because there is, of course, this CKD interaction with outcomes, but even more, it interacts with other diseases. And these is ischemic cardiomyopathy, so heart failure, more or less at number 1, stroke number 2, dementia number 4. That means that there is an over-additive increase of CKD risk. And this, again, is also, of course, confounded by diabetes. Now, what about now diabetes and heart failure development? You can see in the Medicare population the outcomes, meaning the death rate of people with and without heart failure and diabetes. And you can see that is an absolute problematic difference. You can see that people, this is a 5-year follow-up, die in about 80% of the cases when they have heart failure and diabetes. So this is real-world data. It's an old classical study from the Medicare population without the new heart failure treatments. And of course, it always looks a little bit better in outcome trials, but this is now coming from a regular population. And the other thing is, and this is depicted here, the interaction between diabetes and the heart. You can see also that in people with heart failure, and here you can see that here is depicted severity of heart failure according to the New York Heart Association class. The new onset of diabetes is sharply increasing in patients who have more severe heart failure. And the hypothesis is that neuroendocrine activation, which is taking more prominently place in class 3 patients, shifting the blood flow away from insulin-sensitive organs and therefore worsen insulin sensitivity. So that is the idea behind it here. Now, what about the outcome? Heart failure with reduced ejection fraction in CKD. We talked about the CKD and then the new onset of heart failure, but here you can see no CKD and always CKD. That is this difference here. And you can see the more severe the kidney function is reduced, is KDIGO class 4, the higher is the outcome rate. You can see 40% of the people die after 14 months when they are in stage 4 or 5 class of kidney failure, and it is not much better when they are at stage 3, indicating that, of course, the heart and the kidney also interact concerning their death rate. Now, what happens, and this is an attempt to explain of whether there is indeed a pathophysiological relationship when heart failure is successfully treated. So shifting away back the blood to insulin-sensitive organs. 3 studies I just wanted to mention to you. This is the SHARM trial. You can see very classical one here from 2005. You can see the incident diabetes on candesartan and placebo. And what you can see that there is over a time of 3.5 years, there is a 22% reduction of new onset of diabetes. Candesartan, what about sacubitril/valsartan? Same thing. So this is the extension and more innovative therapies, interaction between heart and kidney. It goes vice versa. You can see enalapril. So this had an active control, which is already good. But by adding the component of an inhibitor of neprilysin, further improves the outcome rate in these patients. And lastly, and this is here data from the DAPA-HF study, you can see the new onset of over diabetes with an SGLT2 inhibitor. That is not very surprising because it reduces glucose, but you can see also that there is, and again, about 30% reduction of new onset of dapagliflozin. That means comorbidities affect heart failure, and a good heart failure treatment might affect comorbidities. And I made the point here for the case of diabetes. Now, there is, of course, an increasing role of comorbidities. Comorbidities increase if people get older. And of course, and I will come later to this, people with a preserved ejection fraction, they are older, so they have a higher load of comorbidities. Now, what you can see here is different death causes in patients from DAPA-HF and DELIVER. So it's a very timely analysis here. And what Professor Petrie is involved, of course. And you can see the lower the ejection fraction, the higher is the rate from sudden death and heart failure death. But when it comes to higher ejection fraction, there is a higher proportion, relative proportion of non-cardiovascular deaths. And this is believed to be carried by comorbidities, and they are increasing over time. This is non-cardiovascular deaths. You can see it is increasing from 2002 to 2003 now to 2018, and cardiovascular deaths is, of course, reduced because, of course, here we have better treatments and there are more outcome modifying treatments which are shown here. And here you can see it on the right-hand side. Sudden cardiac death is, of course, also, it's much lesser. This is the light blue here. And again, non-cardiovascular deaths, here are the absolute numbers go up. And they are more than 50% now compared to the years in the beginning of this century. So with having said that, of course, the question is, how do the number of outcomes and the number of comorbidities affect outcomes? And this is kidney metabolic outcomes. And you can see in the SHIFT study, which is old, the cumulative proportion of kidney comorbidities, regardless of what it is, 1, 2, 3, and 4. And you can see that people with more than four comorbidities, which you can see were approximately as many as no comorbidities, about doubling the risk of cardiovascular death and heart failure hospitalization on placebo and ivabradine. And a little bit hidden in between these two curves is a 20% reduction of ivabradine. There was no heterogeneous effect, but you can see that the number of comorbidities indeed has a much greater impact than the treatment effect of the single component. Now, very new, here data from people with cardiometabolic overlap, and these are the cardio-renal metabolic conditions. 0 to 3, same picture, approximately a doubling of outcome rates, cardiovascular deaths, all-cause deaths, and heart failure events, indicating how important these cardio-renal metabolic conditions are to increased outcomes. What about beyond outcomes? This is reduced ejection fraction and patients with preserved ejection fractions. And you can see different comorbidity numbers. And it does not only affect outcomes, people a little bit expectedly, of course, who have more comorbidities for, of course, they have a reduced quality of life. So that is, I think, a little bit self-explanatory. However, quality of life and also quality of life and exercise tolerance are reduced. And this is a mandate also to have a look treatment-wise on these comorbidities. Now I come specifically more to CKD. This is a new paper from Paradigm and Atmosphere. Professor Petrie was involved. And you can see here the individual risk and all different combinations of cardiovascular outcomes. You can see here the population attributed fraction, so the majority of CKD and HDN. But when you then look what is kidney, then you can see that the most prevalent comorbidity combinations all have kidney in there. And of course, this increases the outcome rate. Now, how does it look like here in this registry from Europe? CKD is the most prevalent comorbidity. You can see also it's a little bit more prominent in heart failure with preserved ejection fraction. And the reason for this is that these are elderly people, older than these people with reduced ejection fraction. So therefore, one selects people with a little bit higher comorbidity load. And this works across all different types of comorbidities. But the most prevalent and important comorbidity, maybe not important, but prevalent comorbidity is CKD. Now, how is CKD affecting outcome? You can see it here in heart failure, preserved, reduced, and mildly reduced ejection fraction. There is, in patients on dialysis, an up to 5-fold increase of risk, and zwar in hospital mortality. In acute heart failure, this is the same also in chronic heart failure. And the risk is going to increase, of course, sharply to a doubling in event rate from 30 to 45. So it's not only dialysis, it starts quite early. And why is that so? And that is the reason is that people with a poorer glomerular filtration rate, which is shown here, are less intensively treated with an ACE inhibitor and an ARNI. An MRA, of course, because the fear of hyperkalemia is there. And the triple therapy is in particular poor. It is poor in general, but it is also even poorer, and not to say catastrophic, in people who have a really poor eGFR. And the light bars are below 30. These are is a margin where the people indeed might have a true contraindications. Yeah, but when you then look how many people have indeed a beta blocker which can carvedilol given until dialysis, there is not a complete treatment. And even in patients who have an eGFR of 45, there starts a drop of treatment intensity, even though it could be given in these patients. So now, is there a direct association of heart structure and function to eGFR? Here you can see the p-values, and indeed, in this population adjusted to everything one could get, there is a reduction to, or there is an association to end diastolic volume, also to E to E prime, not so much expressed, but also to left atrial volume index, indicating that also the phenotype of the heart here in the RX study associates to poorer function. Now, how frequently is it, and how much is indeed the outcome rate affected? These are patients with mildly reduced ejection fraction, and the event rate when you have all combinations of them, yeah, CKD, cardiovascular disease, and type 2 diabetes is of course twice as high as in patients who have only cardiovascular disease, here depicted in yellow. Again, showing that there is a stepwise increase of outcomes where the more of these conditions are combined. Now, finally, what is the role of the kidney? This slide I bought from, I've stolen more or less from Professor Wanner, a nephrologist in Würzburg in Germany. And you can see here the journey of a patient. The creatinine, eGFR, gives you the cliff where you are falling down into dialysis. But the speed on how you move to these cliffs is determined by urine albumin excretion. And I would like to make the point, if you truly want to have a prediction of the outcome and the kidney outcomes, then urine albumin excretion is necessary. And here you can see the incidence rate of chronic kidney disease and heart failure according to albumin excretion on the different levels of kidney function. This is eGFR. And you can see, of course, that within each level of CKD, there is an association of progression with albuminuria. And this indicates what I've said before. It gives you the speed. So CKD and cardiovascular disease is affected manifold, environmental, diabetes, age, and of course, cardiovascular conditions such as hypertension, and then at the end of the day, heart failure. Now, what about acute interventions? So cardio-renal interactions in the acute interventions. How speaks the kidney to the heart? Now, cardiac output is going down. This produces forward failure and a reduction in renal perfusion. Renal perfusion is sensed by the kidney, and then there is renin-angiotensin aldosterone activation to furthermore increase perfusion pressure. And this, of course, in the long run has adverse effects on the heart. Afterload increase initiates cardiac remodeling processes, and also sodium and water retention increases wall stress of the heart and also leads to edema formation and congestion of the kidney, most importantly, indicating that indeed the blood flow is increasing, the congestion is going up here, and the transglomerular pressure gradient is dropping. And this is, of course, the acute problem when there is acute volume overload because the pressure gradient is going down. That is backward failure and therefore less filtration. And if then there is an increase in these or a drop in filtration rate, further augmentation of water retention occurs, and this increases the preload and therefore affects the heart in an adverse way. Now, this can be addressed by RAS inhibitors. That's what we are doing, and aldosterone antagonists. And we can reduce also afterload and sympathetic generation and heart rate by beta blockers. So first of all, diuretics are the mainstay to reduce volume overload and also to decongest, of course, the kidney. How can it be seen? That is very easy. You can do a Doppler, a duplex of the kidney. You can do it in all different veins, and it looks more or less the same. But here is the kidney. This is normal. You have a pulsatility flow in the kidney with a diastolic flow because there is flow during systole and diastole. If the kidney is congested, so there is an increase of the vascular resistance in the kidney, then you can see that there is only a monophasic flow. So just looking into congestion in the organs is easily possible. You can see it in the portal vein, and you can see it also in the kidney vein, and this indicates to you that the kidney should be further decongested. How this can be done? So the classical way is, of course, a loop diuretic, which act here in the Henle's loop of Henle, just by inhibiting chloride transport. There is more sodium arriving here, but there is also more sodium reabsorption. So there is the self-limiting effect of thiazide diuretics. So it makes sense also to inhibit other things, and this can be done, of course, by carboanhydrase inhibition, can be done by thiazide and also spironolactone, and by SGLT2 inhibitor, which is referenced here, which of course has here is able to increase sodium excretion in the proximal tubule. And this has been shown by Christian Schulze in the EMPER-HF study. So what you can see with this heart failure and diabetes drug, one is able to increase the urine volume at the end of the day, and also one is able to facilitate the effects of other diuretics. So this is called here diuretic efficiency, which is significantly increased. And looking into a meta-analysis, you can see that cardiovascular death and heart failure hospitalization and also the use of diuretics decongestion is in this meta-analysis significantly improved by SGLT2 inhibitors. Now, how does it work? And what is maybe a little bit of an advantage in these more soft dehydration? There is interstitial drainage because it's not a rapid depletion of the intravascular volume. There is osmotic diuresis and natriuresis, and this, of course, reduces a vascular volume. There is hemoconcentration by a loss in water, but also maybe by an increase in hematocrit. Yeah, this relates to the endogenous formation of erythropoietin, and of course, therefore, there is a change in exchange between the plasma volume and the other intervascular volume and the interstitial compartment, and this small and also slow removal of fluid means that the patients are more likely to get euvolemic here. So that is what has been done, while furosemide rapidly removes fluid from the intravascular compartment. So maybe the combination makes sense, as has been shown in the IMPACT study. Now, if then we look into the interaction with diuretic and empagliflozin, so the effects on the kidney, and this is a secondary analysis from EMPEROR preserved, you can see that there is more frequently with diuretic a discontinuation of diuretics independent of the dose, which is shown here. This is a p-value. You can see also that there is less time for a diuretic to be increased. And finally, there is more likelihood for de-escalation of diuretics, indicating that the concept we're discussing are correct. So there is a sparing effect of diuretics. Now, this is an association, but it might be very important because when in this cohort of patients, this is a British study, Teresa McDonough and John Cleland have looked at that. They took patients with a decreasing of the loop diuretic or withdrawal even, and then in different populations of heart failure, and looked also at dose increases. And the trajectory of outcomes are depicted below. Yeah, you can see the dose of diuretics, and it is increased. And then, of course, there is indeed a better outcome, indicating that patients who have a less dose of a diuretic get better. So this is just maybe not only an association, but it makes sense that diuretics are reduced. What about heart and kidney protection? You can see these are the first data from EMPERACT outcome study, and there was a reduction in the primary endpoint, cardiovascular death, MI, and stroke, primarily carried by cardiovascular death. But what you can see here that this, which was not even an endpoint, heart failure hospitalization, was significantly reduced by 35%. And this was replicated by other SGLT2 inhibitor studies, is EMPERACT outcome, CANVAS program, and DECLARE. And therefore, there is a class 1 recommendation for the prevention of heart failure because only a minority, 10% in EMPERACT outcome, indeed had heart failure. So the majority had diabetes, but not heart failure. So prevention of heart failure. The next step then was to move to heart failure trials, and you're all familiar with them. This is the DAPA-HF trial and the EMPEROR Reduce trial. And you can see indeed curves start to separate early, and there is a 25 and 26% risk reduction without heterogeneity between the compounds to improve heart failure. And this is independent of diabetes, so that works in diabetics and no diabetics. You can see there is no interaction with the baseline HbA1c rate. There's an important study by Professor Petrie. There is no interaction at all, and also not an EMPEROR Reduce. So there is a high level of agreement between two trials. So therefore, independently, it works. Now, what about diabetes is clear. What about kidney protection? What SGLT2 inhibitors are doing, they make the kidney sense a high sodium level and in the vas efferents, and then the kidney thinks it loses sodium and produces a constriction of the vas afferents, so a reduction of the kidney blood flow into the glomerulus, because of course this vasoconstriction reduces the blood flow, and therefore there is a small dip in the beginning, but thereafter, due to the drop in glomerular filtration pressure, it gets flatter here, and this is the outreach for the kidney protection in the kidney. And this is here taken from the PRESERVE trial, and you can see it gets flatter, and the slope, which is called this effect, is getting more flatter. So there is clear protection of the kidney in by SGLT2 inhibitors, and this is independent of the baseline kidney function. You can see eGFR 90 to 30. There is no heterogeneity between the cardiac outcome effects, and also there is in another analysis all these endpoints are not associated or are different between the different kidney functions. So independent of the heart condition, kidney protection is taking place, but the relative risk is the same, but the absolute risk is so different. So the protection of the kidney, the absolute risk reduction is better in people, tends to be better and higher in people with high risk. So therefore, there is no reason not to give it to these patients with impaired kidney function. The next point is other high-risk conditions, and this is, of course, high-risk KDIGO categories, which I just showed you is no interaction. What about low blood pressure? Indeed, low blood pressure is not affected. This is taken from EMPEROR Preserved. Kidney protection in elderly and low blood pressure. These are elderly, are not different according to what is shown here. This is the eGFR slope, and the same holds true for blood pressure. Low blood pressure below 110 has the same kidney protection as high blood pressure. So again, all these risk conditions do not affect with the kidney protecting effect. And this is also the case in diabetes. You can see here heart failure outcomes across all the different trials with diabetes in CKD. Heart failure outcomes, there is no interaction with the transition. Now, this leads finally to the point that there is protection in the kidney and CKD with a class 1 recommendation for both of the drugs, and this is also related to kidney studies. And it is related to a second compound, a non-steroidal aldosterone antagonist, which has shown in the Fidelity study, which is a meta-analysis from 2 trials, a composite cardiovascular outcome to be reduced, but also heart failure hospitalization to be reduced. So SGLT2 inhibition and finerenone as a new MRA has shown to protect the kidney and also have shown to protect the heart, because heart failure hospitalization is reduced in people who have not heart failure at baseline when treatment is started. So this is the concept of everything, and this is our comment on the heart failure guidelines. Kidney protection, CKD, kidney outcomes are reduced, but also cardiovascular outcomes are reduced in patients who have only a small prevalence of heart failure already. So this gives the indication for heart failure. In CKD, renal endpoints are reduced. And of course, in heart failure studies, it's the other way around. CKD is reduced, and this shows you the interaction between the different conditions of the cardio-renal-metabolic syndromes. So what is the concept? First of all, this is the combination of RAS inhibition and aldosterone inhibitors with SGLT2 inhibitors. And this is here from the different renal trials. And you can see the combination is further improved compared to the single components. And this indicates that these interactions apparently are independent from each other, showing the close interrelationship. Here the Kaplan-Meier curves, and of course the years which are gained in these combination treatments in patients with CKD without diabetes, and the treatment effect is huge, indicating it works also without diabetes, these effects, and in the absence of heart failure. So now what is the concept of risk modulation? What you've seen is a close interaction between the kidney, the metabolic system, depicted by the pancreas, and the heart. So first of all, CKD increases heart failure. CKD increases diabetes because it has a strong impact of insulin metabolism, which there are no direct data. Diabetes increases CKD and heart failure increases diabetes and CKD. So this is the cardio-renal-metabolic interaction, and SGLT2 inhibitor as one, in addition to RAS inhibition, which are all present in the main study. RAS inhibition already reduces the heart failure outcome, it improves the kidney and delays new onset of diabetes. And in kidney disease, kidney outcomes are reduced, cardiovascular disease and heart failure prevalence is reduced, and the new onset of diabetes is of course reduced. And finally, in diabetes, glucose markers are improved, renal composites are reduced, and cardiovascular disease and heart failure outcomes are reduced. And this shows that there is a pathophysiological interaction, but also in the different indications, the application of SGLT2 inhibitors also improves the alterations in the other organ. So cardiovascular protection is something which comes together in all of these 3 conditions. With this, I would like to thank you for your attention. Thank you very much.
Thank you very much, Professor Michael Bohm, for this comprehensive and overview of the interrelationship between all the components of the CRM and their contribution to hard endpoints, and the central importance of SGLT2 inhibition in the management of those patients and reduction of hard endpoints. We now move to the second lecture, which will be given by Professor Mark Petrie. He comes to us from the Institute of Cardiovascular and Medical Sciences, University of Glasgow, UK. He's a board member of the Heart Failure Association of European Society of Cardiology and chairs in heart failure group. He's going to highlight the rationale for early intensification with SGLT2 inhibitor and the comprehensive treatment approach. Mark, the screen is yours.
Thank you very much, Dr. Almahfouz. It's a pleasure to be here. And I have to say, I really enjoyed Michael's lecture. It really is a thoughtful setting the scene between the heart and the kidneys and diabetes. So really phenomenal lecture. So I'm going to dive now into practicalities and the rationale for SGLT2 inhibitor treatment. I'm going to focus mostly on heart failure, but also touch a little bit onto chronic kidney disease, and also give you a flavor for some of the trials we're going to see coming out over the next few months and years. So the take home is that heart failure is a fantastic thing to manage. In many areas of medicine, we can make very little impact on the outcome of our patients. But in heart failure, we can make a major impact. So if we look at these data for heart failure with reduced ejection fraction, these are using data from the Emphasis trial with eplerenone and Paradigm HF, the sacubitril valsartan, and DAPA-HF with dapagliflozin. We can see here the profound benefits that patients get if we use our drugs effectively. So in this analysis, we compare the old-fashioned way of looking after heart failure with reduced ejection fraction, with ACE inhibitors and beta blockers, with using modern therapy with RNAs, so sacubitril valsartan, beta blockers, MRAs, and SGLT2 inhibitors. You can see here that the treatment effect is really remarkable, with around a 50% reduction in mortality and about a 60 to 70% reduction in hospitalization. So I think all of us, we do lots of heart failure clinics, lots of heart failure management. We see people who 20 years ago were doing very badly and dying and being hospitalized with a poor quality of life, really doing very well. We see people actually recovering their heart function. So it's probably the most rewarding area of medicine to be involved with. So I think all of our patients deserve to be treated appropriately with a modern medical therapy. So until 2015, we had no data in this area at all. And now we have an avalanche of different trials in different disease areas. So I'm going to go through these different trials, as I say, focusing mostly on the heart failure trials, but also a little bit on the chronic kidney disease trials. So the first data I'm going to discuss are the data for heart failure with reduced ejection fraction. These are the large, poorly contractile hearts. So the first trial I want to talk about is Emperor Reduced. And this is the trial looking at empagliflozin at a dose of 10 milligrams compared to placebo. The patient population is a very simple patient population, patients with heart failure and reduced ejection fraction that we see every day in our clinics. So people with left ventricular ejection fractions less than or equal to 40% and modestly elevated end-term BNPs. A very few exclusion criteria, so EGFR less than 20, systolic blood pressure less than 100, and type 1 diabetes. So the primary outcome is of cardiovascular death and heart failure hospitalization as a composite outcome. And you'll remember that in Emperor Reduced, we saw a 25% reduction in cardiovascular death and heart failure hospitalization. That was in relative terms, or a 5% absolute risk reduction. So we look at the speed of the benefit of therapy with empagliflozin, we can see that we saw a rapid benefit. Certainly within a month, we see rapid separation of the curves of empagliflozin and placebo. So this is the kind of thing that we think when we see our patients in clinic or on the wards. We think, let's institute this therapy early rather than waiting around for months while the patient is not feeling well and at risk of hospitalization. Looking at the secondary outcomes, this is the one of the key secondary endpoints from Emperor Preserved, which is total, as in first and recurrent hospitalizations for heart failure. We can see here these were reduced by 30%. We look at another key secondary endpoint. This is the rate of decline of EGFR, so the EGFR slope. And we see that over the course of the trial, patients on empagliflozin have a slower rate of decline of EGFR than in placebo. I think all of us as clinicians know that when we start these drugs, we do see a small transient reduction in EGFR, this is a hemodynamic effect rather than acute kidney injury or acute kidney harm. And as I say, by the end of the trial, we see the benefit manifesting. So as well as hospitalizations and renal function, the patients that we see, of course, the main thing we talk about in clinical situations is quality of life or health status. People want to feel better. They want to be able to do their shopping. They want to climb the stairs. They want to be able to walk. So we see with empagliflozin in HFrEF, we do see an improvement in quality of life measured by the Kansas City Cardiomyopathy Questionnaire. So Michael's already shown you data showing the benefits of SGLT2 inhibitors in patients with and without diabetes in heart failure. There was a time when these drugs were thought to be diabetic drugs and people used to check the HbA1c before prescribing these drugs. But I think we're all now confident these drugs are beneficial regardless of the diabetic status. And again, Michael's already shown you this, looking at baseline HbA1c. Doesn't matter what that is, we still see the reduction in cardiovascular death in heart failure hospitalization. So certainly in our cardiology clinics, our heart failure clinics, we don't use HbA1c to decide whether or not to start SGLT2 inhibitors. So just to look at some more endpoints in EMPEROR-Reduced, there was a lot of diving into the data. There wasn't just heart failure hospitalizations that were reduced, it was severe heart failure hospitalizations, those requiring coronary care or intensive care, but also urgent heart failure visits. These are visits when people come up and receive intravenous diuretics as outpatients and are not hospitalized. So really convincing benefits. There's been a lot of discussion in Twitter or X about exactly what hospitalizations are reduced by SGLT2 inhibitors. You can see here in EMPEROR-Reduced total all-cause hospitalizations were reduced by empagliflozin in EMPEROR-Reduced, as well as cardiovascular hospitalizations. So adverse events are really important to talk about when we talk about SGLT2 inhibitors and to understand. And we see consistently across the trials that serious adverse events are less common with SGLT2 inhibitors, and adverse events are certainly not increased. There used to be a concern about things like volume depletion or hypotension, and we really didn't see that. I'm going to come back to ketoacidosis, but in EMPEROR-Reduced in the 3,700 patients over about 18 months, we didn't see any ketoacidosis events, despite lots of hospitalizations. So this has been overstated. What definitely does happen is genital tract infections, and these are certainly something we need to talk to patients about when we use SGLT2 inhibitors. I'm going to come back and talk about that in a minute. So another commonly misunderstood thing about SGLT2 inhibitors is the blood pressure effects, and certainly these drugs cause minimal blood pressure effects. If we look across the whole programs, we see about 1 or 2 millimeters systolic blood pressure drop in patients receiving SGLT2 inhibitors. So we encourage our nurses, our pharmacists who are starting these drugs not to be concerned, as long as the blood pressure begins in our practice above 90, in the trials above 95 or 100. There's also an interesting phenomenon. If the blood pressure starts a little bit higher, we see more blood pressure reduction. And if the blood pressure at baseline is lower, so less than 110, we see less systolic blood pressure reduction. So the take home is these drugs have minimal impact on systolic blood pressure. There's also a lot of discussion about the effect of empagliflozin on top of different baseline heart failure therapy. And we've done lots of analysis over the trials, and these are data from EMPEROR-Reduced showing that empagliflozin has additive benefit on top of any combination of baseline therapy. So we don't have to wait until somebody's on maximal dose of skutolsartan or MRAs or whatever. If they're on small doses or large doses, whatever the combination, we see incremental benefit. So just to look at the other trial in this area, this is a sister trial to EMPEROR-Reduced with the empagliflozin and HFrEF. Very similar trial, slightly bigger, but using dapagliflozin 10 milligrams as opposed to empagliflozin 10 milligrams. And you really see here really very similar results between DAPA-HF and EMPEROR-Reduced. Here we see a 26% reduction in the composite of cardiovascular death heart failure hospitalization and urgent heart failure visit. And again, the same rapid benefit here we saw with Emperor reduced. Here we see with DAPA-HF the same finding, that within a month we see a convincing and a sustained reduction in the primary outcome. So that's heart failure with a reduced ejection fraction. I'm now going to move on to HFpEF, heart failure with preserved ejection fraction. These small, usually hypertrophied hearts with big left atria. So the biggest change recently was the 2023 update of the European Society of Cardiology guideline to give SGLT2 inhibitors a class 1A recommendation across the spectrum of left ventricular ejection fraction. So for HFrEF, for HFpEF, and also for this intermediate group, the mildly reduced ejection fraction. So you can see here it's not just class 1, but a class 1A recommendation in mildly reduced and preserved ejection fraction. So this has been universally accepted and I think translated into routine day-to-day clinical practice. So what are the data that resulted in the change in the guidelines? So the first trial to be published in this area was Emperor Preserved, a trial of HFpEF comparing empagliflozin, again 10 milligrams against placebo. And again, a very typical population that we see in our heart failure clinics every day, people with ejection fractions greater than 40, so mildly reduced and HFpEF, slightly elevated end-terminal proBNPs, and either structural heart disease or a hospitalization for heart failure within 12 months. And the same exclusions that we saw in Emperor Reduced, the eGFR less than 20, systolic blood pressure less than 100, and type 1 diabetes, and the same primary outcome of cardiovascular death and heart failure hospitalization. So again, the primary outcome in Emperor Reserve is positive, with a 21% reduction in the composite of cardiovascular death and heart failure hospitalization, 3.3% this time absolute risk reduction. And again, just to emphasize the rapidity, the speed of benefit we see with empagliflozin in HFpEF, this time the first statistical significance signal was at 18 days. So again, looking at the key secondary endpoints again, the same as Emperor Reduced, so total, so first and recurrent hospitalization, we see this 27% reduction in this secondary endpoint. And again, looking at eGFR slope, the rate of decline of eGFR again favored empagliflozin. We saw the same early dip in eGFR, but then we see the catch up and then the improvement in eGFR. What about first hospitalization for heart failure? So here we see a 29% reduction in that endpoint. And again, the Emperor team went to town on looking at many of the endpoints. So here we see lots of combinations of all-cause mortality and cardiovascular mortality and different types of hospitalization, everything reduced by empagliflozin in HFpEF, with the exception of total any-cause hospitalization, which was not quite statistically significant. So looking at the heart failure events here, similar to Emperor Reduced, we saw a reduction in urgent visits, these intravenous diuretic visits, reduction in outpatient visits, and reduction in severe heart failure hospitalization. So really convincing and consistent benefits. And again, looking at quality of life or health status assessed by Kansas City Cardiomyopathy Questionnaire, here again, we saw the benefit in terms of improvement in quality of life. So turning now to DELIVER, this is the sister trial to Emperor Preserved, but this time with empagliflozin. Again, a very similar population with one or two differences. Primarily, in DELIVER, people with improved ejection fractions, or people who previously had low ejection fraction but improved to an ejection fraction above 40% were included. And also people who were hospitalized or recently hospitalized were also included. So you can see here the primary outcome again was positive, this time with an 18% reduction in cardiovascular death or worsening heart failure. Looking at the components here, we saw a 21% reduction in worsening heart failure. The cardiovascular death and hazard ratio was 0.88, and that was not statistically significant. So looking at these subgroups in DELIVER, we saw the consistent benefit across ejection fraction, so greater than or equal to 60, 40 to 49, or 50 to 59. The population were hospitalized or recently hospitalized within 30 days. Again, we saw a benefit in both the groups, whether or not they did hospitalization or not. And again, people with improved ejection fraction, we saw improved in a similar manner to people who had HFpEF without prior reduction in left ventricular ejection fraction. So there's been lots of meta-analyses after DELIVER and Emperor Preserved. If we put the data together, we see this consistent finding for SGLT2 inhibitors and HFpEF with a 20% reduction in cardiovascular death or heart failure hospitalization. If we look at heart failure hospitalization by itself, there was a 26% reduction looking at the two trials together. Cardiovascular death, looking at the two trials together, is frustrating with this 12% reduction with a borderline p-value of 0.052. So again, the meta-analysis looked at this feature across ejection fraction, and we can safely conclude there is benefit across ejection fraction in people with HFpEF. So turning away from HFpEF now into management of hospitalized or acute heart failure, the guidelines have also gradually changed. And here you can see these really interesting words that have been adopted by the ESC guidelines, that when you have a hospitalized patient, you should have an intensive strategy of initiation and rapid up-titration before discharge and during frequent and careful follow-up in the 6 weeks following hospitalization with a class 1 level of evidence B recommendation. And there's actually been a trial, which I'm going to talk about in a minute, which has come after this to further strengthen that recommendation, but really quite a good recommendation to recommend quite strongly that before people go home, we should be instituting and establishing people on good medical therapy for heart failure. So the wording also goes on to say that we should be maximizing or administering evidence-based oral treatment before discharge, and then quite clearly recommending a visit 1 to 2 weeks after discharge to look at drug therapy. So I'm not sure how much that happens across your regions, and maybe we can discuss that. So what are the data to support SGLT2 inhibitors in hospitalized patients? So this is the first trial. This is the Impulse trial, which randomized 530 people with HFrEF and HFpEF and looked at the efficacy and safety in hospitalized patients. And you can see here we saw clear reinforcement of the efficacy of empagliflozin in hospitalized patients with this hierarchical endpoint of death, heart failure hospitalizations, and quality of life improved by empagliflozin. Safety is also very important when we think about hospitalized patients, and these data from Impulse are really very strong, showing fewer adverse events with empagliflozin compared to placebo, and also fewer serious adverse events as well. So some people have been anxious or concerned about using these drugs in hospitalized patients. These safety data from Impulse were actually really important in reassuring us that these drugs were not just safe, but also efficacious. Again, there was also concern about whether you'd have renal failure or volume depletion or hypotension. We didn't see this in Impulse. I will come back to genital tract infections in a second. So the other data in hospitalized patients or recently hospitalized patients was a soloist trial. This was 1,200 patients randomized to sotagliflozin, this SGLT1/2 inhibitor combination against placebo. And you can see here, we had this 33% reduction in total cardiovascular death or heart failure events, but again, a very rapid separation of the curves or clinical benefit seen for patients. So this year we're going to see, or early next year, we're going to see a publication of a further trial in hospitalized patients with the dapagliflozin called DAPA-ACT Heart Failure TIMI-68. This is a large trial, almost 2,500 people with hospitalized heart failure. You can see here the primary outcome is time to cardiovascular death or worsening heart failure. So I do want to talk about DKA, and it's important to say that diabetic ketoacidosis is increased by SGLT2 inhibitors, but the effect is very small. In Emperor Reduced, I've already said there was no cases across the whole trial, despite lots of hospitalizations in heart failure patients. If we look at Emperor Preserved, interestingly, there were more ketoacidosis, small numbers in both groups, but 5 in the placebo group and 4 in the empagliflozin group. And DAPA-HF in the 4,700 patients, there was 3 events in the DAPA group and 0 in the placebo group, and DELIVER 2 in the DAPA group, obviously all with diabetes. If you don't have diabetes, you're not going to get DKA. So the take home here is there is a very small incidence of diabetic ketoacidosis. Everybody should be aware of it. People should be vigilant. They should test for it if they're suspicious. But please don't withhold excellent therapy that reduces mortality and hospitalizations, improves quality of life, and has beneficial kidney effects on the basis of a fear of DKA. What we can do is we can obviously look for DKA and be vigilant in situations where DKA might happen, and I'll come back to that. So genital tract infections, again, do occur. This is not like DKA. DKA is very, very, very uncommon. Genital tract infections do happen, and we need to talk to our patients about them, and we need to try and prevent them by encouraging good genital hygiene. We need to tell our doctors, nurses, and pharmacists about these things. A lot of cardiology teams have never dealt with genital tract infections. We need to tell them that they happen when people first start taking the drug. They happen in about 1 in 100 cases, or possibly 1 in 150 cases. We need to educate our heart failure teams not to stop these drugs when genital tract infections occur. You treat them, and they don't come back very often. It's about 3 in 1,000 cases where you have to stop SGLT2 inhibitors due to recurrent genital tract infections. And they're easily treatable. All primary care physicians know how to treat genital tract infections, which are very common in their patient populations every day. So an important question is, when do I not use SGLT2 inhibitors? So type 1 diabetes, I don't think cardiologists should be using these drugs in people with type 1 diabetes. If you want to do that, you should be talking to your endocrinologist, your diabetes specialist, and learning from them. eGFR less than 20, we sometimes do start these drugs at eGFRs less than 20, but I only do that in collaboration with my kidney doctor colleagues. If somebody's had previous DKA, I would not start SGLT2 inhibitors. So what about sick day rules? Again, we hear lots about sick day rules, and we hear lots of different opinions about these. And it's fair to say that there was a problem for a while when people were stopping these drugs, and everybody who is hospitalized for any reason, so even people coming in for a day case angiogram, a day case PCI, people were stopping these drugs, and we were seeing them not getting started again. So the take home is we should be stopping them when we're worried about DKA, and that's people who are very unwell. So major sepsis, prolonged fasting, or major changes in insulin doses. So people that are very unwell or fasting or septic, yes, we should stop these drugs, but not for minor chest infections or minor hospitalizations. We should be continuing these drugs, because every time you stop drugs, there's a reasonable chance they won't get restarted again. So what about collaboration with other team members when you're using SGLT2 inhibitors? Primary care are extremely important, and it's all about communication and collaboration. So some primary care doctors don't know these drugs are used for heart failure management or kidney disease management. So it's useful to explain why you're using them. We explain the lack of the need for monitoring. As we all know now, we don't have to do any extra monitoring. We just use the same monitoring techniques and frequency of blood tests as we do for any other heart failure patients. We do need to listen to them as well, because people in primary care have been using these drugs as diabetes therapies for quite a long time. So a lot of them have got very valuable experience. And also they've got valuable experience in managing genital tract infections. So we need to speak to primary care physicians, communicate why we're using them, and learn from them as well. What about diabetologists? So diabetologists can be very anxious about DKAs. They see a lot of DKA, and they see a very focused group of patients. So they don't see the many patients going through cardiology departments who do not have any problems with DKA. So we need to talk to them about it and ensure they're not overly anxious about DKAs. We also need to reassure some diabetologists about sick day rules. Sometimes they're overly enthusiastic. Maybe we can discuss this about sick day rules. We also need to work with our diabetes teams to ensure they recognize heart failure. A lot of people in diabetes clinics, as Michael's been talking about, have heart failure. Over the years, it's been under-recognized. And again, they have a lot of evidence showing the kidney benefits of SGLT2 inhibitors. So just some practicalities, what do I do? So in patients, if we have a patient who presents with heart failure, low ejection fraction, with congestion, we start dapagliflozin and MRAs in the first few days. When the patient's stable and intravenous diuretics, we'll start sacubitril/valsartan. And when the patient's dry, we'll start beta blockers. So really pretty straightforward. There's a huge amount of discussion about how to start the heart failure drugs and heart failure with reduced ejection fraction, and a lot of debate. I think it's safe to say that most people now do no longer go through the very slow conventional approach where you start one drug, titrate it through the doses, then start another and titrate it, and take months to get on the right therapies. And most people in clinical practice now are starting drugs in a more rapid way. Exactly how you do this is debatable, and frankly, I think there's no one right way to do it, but we should be trying to get all the drug classes on board. I think within a month is reasonable, and titrate to top. So why did people used to titrate slowly? It was really based on the publication history and really not much else. But we've realized it's inefficient for patients, it's inefficient for doctors, and really if we're trying to get things done quickly and realize the early benefits, we should do this more rapidly. So we've done a lot of work thinking about the best sequencing for heart failure drug therapy. This is a paper we published 2 years ago now. And the best treatment in terms of reducing outcomes, according to our modeling of lots of trials, was SGLT2 inhibitors first, followed by MRAs, then RNAs, then beta blockers. Even this timeline actually is probably a little bit conservative for what most people are doing. Some people have recommended simultaneous initiation of therapies, which I personally think is probably not the best idea to start all drugs in the same day, because if something happens, then you can result in having to back off on all the drugs. So I personally don't think that simultaneous initiation as in the same day is a good idea. And really, all of you as clinicians will see lots of different types of heart failure patients with lots of different clinical characteristics. And I encourage our teams to look at the individual patient and tailor the therapy towards individual patient and do things as rapidly as they think is sensible. And of course, we need to go beyond the 4 drug classes we've talked about. There's lots of other therapies, which Michael's already mentioned, which we must not forget that are valuable add-ons to our core drug classes. So what do the guidelines say about sequencing? These are the ESC guidelines, and they're quite cautious. They say the guideline still recommends RNA as a replacement for ACE in people who remain symptomatic on the other 3 drug classes. But they state an RNA may be considered as first-line therapy instead of ACE inhibitors. The Americans are less cautious. They say that sequencing in HFpEF is less controversial. There's only SGLT2 inhibitors with an evidence-based currently, so that's not a difficult decision. So the benefits of rapid sequencing are obviously we get rapid benefits, we reduce mortality, hospitalizations, quality of life. We see reverse remodeling is important, so you can avoid an ICD or advanced heart failure therapies. And also for a heart failure team benefit, we also see reduced need for clinic visits, which is really important, certainly in our healthcare environment. And it's obviously good for the patient having less visits as well. So I think what I'm encouraging you to do is think about what your team sequencing strategies are, how fast you do it, what sequence. And we encourage discussion within heart failure teams. Talk to the nurses, talk to the pharmacists, talk to your cardiology colleagues. And if you're talking about it, you'll probably end up doing the right thing. So further data in this area about rapid initiation is a strong HF trial published again last year. So just over 1,000 people randomized to either usual care or a high-intensity strategy. The high-intensity strategy was quite aggressive, started half optimal doses of heart failure therapy prior to hospital discharge, and then at 2 weeks, full doses. You can see here there's a few safety visits at week 1, week 2, week 3, and week 6, with the primary outcome at 6 months of heart failure readmission or all-cause mortality. You can see here the aggressive high-intensity care resulted in a lot more prescription of heart failure drug therapy. And you can see here this translated through to really quite a big reduction, an 8% absolute benefit in terms of the primary outcome with the high intensity care. So what about safety of doing what they did in strong HF? So you'll see here we saw more adverse events, but that's really a reflection of more adverse event capture in the high intensity arm. But serious adverse events were not increased by the rapid initiation. So you can see here they were pretty well matched between the two groups. So moving on to kidney disease trials. Again, I'm not going to talk about this for too long, but we have a wealth of evidence here as well. Lots of great data showing improved kidney outcomes with SGLT2 inhibitors, but also improved cardiovascular outcomes. So here's data from DAPA-CKD with dapagliflozin in people with chronic kidney disease, so eGFRs between 25 and 75. And we see here that we have a 29% reduction in cardiovascular death or heart failure hospitalization. So this is big news for people with kidney disease, and really it has launched a lot of prescription by kidney doctors around the world. I'm going to talk briefly, this is about myocardial infarction and SGLT2 inhibitors, and the first trial here has been published recently called DAPA-MI. This was a trial which really enrolled almost all comers following myocardial infarction and randomized to dapagliflozin or placebo. They had this quite complex primary outcome, which is 7 different components: death, hospitalization for heart failure, MI, atrial fibrillation, diabetes, MOH class, and weight. This was not the original endpoint. They started off with a cardiovascular death or heart failure hospitalization endpoint, but because of low event rates, they changed to this outcome. The outcome was positive, but there was no difference until we got to some of the lower elements of the hierarchy, such as MOH class and change in body weight. In heart failure hospitalization. So the next trial we're going to see is a 6,500 patient trial with empagliflozin. This is a different trial. It wasn't not all comers like the DAPA-MI trial, but with people with heart attacks at myocardial infarction who are at risk of heart failure. So we're going to see these data presented at the American College of Cardiology in April. So just to move on to heart failure teams, and again, this is really important and recommended by the ESC guidelines that heart failure patients should be managed by a multidisciplinary team, including self-management strategies, so Class 1A recommendation. This is based on strong evidence. This is a Cochrane review showing the benefit of multidisciplinary programs managing heart failure, so reducing mortality by 25% and reducing hospitalizations by around 25%. So we've really focused on that in the UK, and we focus on heart failure pathways to make sure that people from primary care and secondary care all are managed within a heart failure team. And looking at the data I presented already, we really must put the care of heart failure patients in the hands of experts who really care about providing them with excellent care. And we should not allow heart failure management to be random. We must have organized optimal therapy within a heart failure team. So the model 20 years ago of a cardiologist by himself seeing a heart failure patient is not acceptable. That's not a heart failure team, and you're highly unlikely to provide optimal management. So when we do a clinic in heart failure clinic, we have a core heart failure team with nurses. These people prescribe drugs, they titrate drugs, they look after the patients, they educate, they counsel. We have medicine for the elderly, which is very important, particularly in our HFpEF cohorts. We have pharmacists, we do the simple titrations and initiations of drugs as well. Our nurses and pharmacists also refer for ICDs and cardiac transplantation, so they do a very good job in heart failure management. And we have very good links with palliative care, with advanced heart failure teams, electrophysiologists and cardiac physiologists. So that happens on several times a week. We have these clinics which are run high volumes with the nurses and pharmacists seeing different people, different cohorts, not the same people as the doctors. So what about HFpEF? I think HFpEF is growing in recognition. We don't see all of the HFpEF people in cardiology clinics, a lot that are non-cardiology clinics, diabetic clinics, renal clinic, all the other clinics. We really need to encourage our non-cardiology colleagues to identify HFpEF and treat. This is also in primary care as well. There's lots of HFpEF. This is under-recognised in primary care. So we're making major efforts to make sure that our primary care colleagues identify and treat HFpEF. And again, in pharmacies, it's amazing. People go to pharmacy, patients, they pick up their loop diuretics, their AF therapies, their diabetes therapies, hugely under-recognised HFpEF in pharmacies. So we're hoping to get NTs around the world in pharmacies. And also we need to make cardiac imaging more easy. And I'm sure you're aware of the explosion of cardiac imaging, artificial intelligence. And take the heart failure diagnostics to where the patients are. I think that's really exciting. Provide all our patients with an intensive best care for heart failure. It's a disabling, deadly condition, which we have lots of tools now to tackle. So thank you for your attention, and I hope we've got good time for a good discussion.
Thank you very much, Mark, for this great presentation. And you certainly have taken us for a tour around all the studies and all the issues that are involved in heart failure management. There is a lot of questions here, but we also have a lot of time. So hopefully we'll be able to go through them. I'm going to start from the beginning, and here you probably have some of those questions. So the first one, just move the chat box a little bit. I can see if I can move it a bit. Okay. So one of them is left artery is narrowed and difficulty in breathing. What do you suggest? Is there an issue with SGLT2 inhibitor probably in such patients? I assume this is what the question is. Maybe if I give this question to Michael to address. So a patient with left artery stenosis, difficulty breathing, what do we do? SGLT2 inhibitors, others, and so on.
So first of all, the question is, the first thing is, of course, to resolve the artery stenosis, so to treat coronary artery disease. The shortness of breath can be due to two things, which can be an angina equivalent. So the first role is to resolve ischemia. And then there could be, of course, because there's already irreversible damage to the heart, there could be an impaired ventricular function due to the loss of the myocardium. So that would then be the heart failure treatment. So first of all is revascularization. If I've taken it correctly, left main artery, yeah, it can be done by intervention or it depends on the morphology, or by bypass surgery. And then what is left over concerning the compromised myocardial contractility, then this would be the area for medical treatment of heart failure. But first of all, the ischemia should be resolved because that is one of the causes of heart failure symptoms. I hope I got the question correctly.
Yeah. So, Michael, I might jump in there. Do you mind if I jump in there? So,
yes, please go ahead.
The revascularization in heart failure is a very controversial subject, and we conducted the REVIVE trial, which we published last year in the New England Journal of Medicine, and we randomized 700 patients with heart failure and reduced ejection fraction and severe coronary disease to PCI or medical therapy. And we found that there was no benefit in terms of our primary outcome, which was cardiovascular mortality and heart failure hospitalization. And that was a big surprise because we were interventional cardiologists, heart failure interventional cardiologists that really thought we were going to see benefit from PCI and heart failure. So we mandated severe coronary disease, severe left, no benefit. So I think it's a really controversial issue that the questioner has brought up. There's also the STITCH trial, which compared surgery against medical therapy, which had all-cause mortality as a primary outcome. and with surgery against medical therapy was neutral at 5 years and showed a small benefit of 16% at 10 years. So there's a very controversial issue about whether or not to revascularize people with heart failure. We're currently conducting a 5-country trial of PCI against CABG in heart failure as well. So it's a very, very uncertain area. And what I've said is controversial and topical. I'm sure Michael probably has a different opinion, because a lot of people think Revived was a trial with many limitations. So, and what to do with coronary artery disease in heart failure is very controversial and topical, but Revived had a hazard ratio of 0.99, so really no signal of benefit.
Mark, this is a different question. I took it the way that this is shortness of breath with a narrowing of left main. That is not chronic heart failure. This is ischemia, and left main is associated to shortness of breath. So revascularization is the first step. By the way, your patients, in the revascularization trial, they had class N NYHA 1 to 2, impaired left ventricular function and ischemia and all these kind of things. But I took the question that there is shortness of breath and the narrowing of the artery without chronic heart failure. In chronic heart failure, it's difficult. So one has to solve the question of whether the shortness of breath is related to ischemia or whether it is chronic heart failure. That is the difference here, right?
Agree. Okay, we agree. Not heart failure, and you've just got left mainstem disease. Yes,
agree.
Agree.
Okay, yeah. So that generated a bit of discussion here. The second question probably should go to Mark, and you did allude to what is the best drug to treat CKD in somebody with stage 3A? I guess mono. Therapy, other therapies, which one to start with, which one to follow, combination, and so on. So there's, again, a very brief question, but it has a lot of applications here.
Yeah, so we'll bring Michael in after me as well, because I think we should try and disagree as much as possible. Michael makes it fun. So I think what's clear from the evidence that we have for SGLT2 inhibitors is that if you have an EGFR of greater than 20, then we should start SGLT2 inhibitors, and that's for both the kidney benefits and the cardiovascular benefits. So I didn't show all the data from all of the trials, but that's a consistent message from the trials. Obviously, that's evidence-based. To be honest, we work with our kidney colleagues, and we actually use these drugs with the EGFRs below 20, but I wouldn't be recommending that to everybody on the call. I think you're safe territory if you're above 20. We also shouldn't forget about
corticoid antagonist because incident hypercalcemia
agree. So I agree entirely. Finerenone, and just for the participants, the trials are Figaro and Fidelio. The Fidelity program clearly show again cardiovascular and renal benefits as well with the Then
a little bit further up to the heart, and we're going to start from the basic where this question is. And again, what is the mechanism of action of empagliflozin? Some speculation. So you can start with that, Michael, maybe? Mechanism of action of SGLT2 inhibitor in heart failure patients.
So low urine output, the question is, what is it? First of all, is it volume depletion? So one can offer the patient a little bit of fluid, and then of course, SGLT2 inhibitor will work. If there is terminal kidney failure with oliguria or anuria, that is a question, and Professor Petrie already alluded, Mark, you alluded that it should be used below 20. That is of course, I think I agree is possible. The question is, and this is something which is also not known, whether it works in dialysis. If the reason for low urine output is indeed terminal heart failure, class CKD class 5, it would be nice to have data to see whether it works, right?
So I did skip that question to go to the heart. So maybe Mark, you can address this mechanism.
yeah,
I
I think Michael tried to avoid the question about mechanism of action of empagliflozin in heart failure patients. Yeah, so I think it's obviously, I think what you said already is true, that there are some things that are known and some things that are speculation. So there are several trials specifically looking at the mechanism of action of empagliflozin in heart failure patients. And we have seen 3 trials that show clear reverse remodeling. So empagliflozin against placebo showing reduction in left ventricular volumes with empagliflozin. We've also seen a variety of other clear effects, such as improvement in renal blood flow. We've seen reduction in pulmonary artery pressures. So those are the facts. There's also many theories attached to what empagliflozin does. And Milton Packer has now written 345 review articles about the different theories about what might be happening with improvement in myocardial metabolism and lots of different other pathways. But those are speculation rather than fact. So we do know that we see reverse remodeling with empagliflozin in heart failure with reduced ejection fraction. We do know we see improved renal blood flow, and we see reduction in pulmonary pressures. I also think some simple things contribute as well. We see some weight reduction with these drugs, and I'm sure weight reduction in some patients has a beneficial action for a variety of reasons. Certainly things like HFpEF, the epicardial adipose tissue has been drawing attention, and renal fat. We also see slight blood pressure reductions, more in HFpEF and HFrEF, which might be beneficial. So I think the take home is there's numerous potential mechanisms, but whatever the mechanism is, we can see the hard outcomes. And as cardiologists, if we see reduction in hospitalizations, reduction in mortality, reduction and improvement in quality of life, that's what's important to the patient and to the doctors in the clinics. And discussion around different molecules and different pathways, probably not that relevant to most patients and doctors.
Great. Do you want to add anything, Michael, about the mechanism of action on the heart, SGLT2 inhibitor, or?
Yeah, it is indeed that there might be not only one mechanism. There is a mediation analysis of all the mechanisms and effects involved and the association to outcomes. So there are a lot of associations. The number one is the increase in hematocrit. So SGLT2 inhibitors takes away the oxidative stress from interstitial fibrocytes where erythropoietin is made. So this increase in hematocrit and the erythrocytes might reduce, in addition to a very mild reduction of fluid, the wall tension in the heart. There is, of course, a lot of metabolic effects. There is an increase of ketone bodies. They are the optimal fuel for the heart concerning the mitochondrial alterations in heart failure. There is one study infusing ketones that increases cardiac output. It is an inotropic effect. The bad side is that slightly increases also heart rate, but this might not be seen in heart failure because you have a beta blocker on board usually. And then there are other things. What is not important is the weight loss, because it's tiny. It is levering out when the beneficial effects occurs, and there is no interaction between baseline body weight and outcomes in SGLT2 inhibitor treatments, but there is only a very tiny or no weight loss in very slim people, so there is no association. The blood pressure has any association, and I think my favorite, I don't know what Mark, what do you think? My favorite is hemoglobin and hematocrit, and the second one maybe the ketone bodies, right? Yeah.
Yeah.
And
so
of course,
my favorite is the reduction of left ventricular volumes, because that's you see that in the clinic, you see patients' hearts improving. So for me, that's great. How that happens, I don't know, but I agree with Michael. There's lots of, I think it's multifactorial. It's certainly heart benefits, kidney benefits, and also I think probably the liver as well. I think there's some benefits to lots of different organs as well. So I think the benefits are multifactorial. The other issue is that we don't know how many other drugs work in heart failure. So how does an ACE inhibitor work? How does an MRA work? There's lots of different questions about how things work. But as I say, the take home is they do work. And, for most patients and doctors and nurses, that's the key thing, is they certainly do reduce clinical events.
I hope it wouldn't take 60 years to know the exact mechanism like it's in metformin. Here's a question again, maybe Mark, you can address it. You did address it in your lecture, which in the setting for acute heart failure with impaired renal function, example, stage 3, would you advise stepwise introduction, or would you introduce both, simultaneously? You did address this, but maybe you can give us your actual way of tackling this.
Yeah, so for acute heart failure, then I'm very relaxed about starting an SGLT2 inhibitor early. If somebody's got acute heart failure and an eGFR of around 30, I wouldn't be starting an MRA in that scenario. So I would be starting an SGLT2 inhibitor, but not an MRA. I would wait until they got a bit better and I was confident that they were stable. From a point of view of the renin-angiotensin-aldosterone inhibition, so ACE, ARB, or sacubitril/valsartan, clinically that's often a difficult decision. So what I do is give people SGLT2 inhibitors with acute heart failure, diurese them with loop diuretics, and then once they're stable, then I will look at the individual patient and make a decision at that point. Sometimes we do go in with a sacubitril/valsartan. If somebody's eGFR is 50, I will easily start sacubitril/valsartan if their blood pressure can tolerate it. So I would be quite comfortable, but I would do that at the low dose, the 24, 26 twice a day or 50 twice a day. So if it's all about the different individual patients. So if somebody's got a good eGFR, I'm happy to initiate sacubitril/valsartan. If somebody's got an eGFR of 30 and they're just coming off intravenous diuretics, I wouldn't do that. So it's a matter of clinical skill, clinical balance, but trying to make sure before they go home, they end up on the right 4 drug classes. So you can't say there's one answer for the spectrum of stage 3 CKD, because that's a broad spectrum you're covering with stage 3. So is somebody with eGFR of 30 is different than 35, 45, 55. So I would encourage people to work with their heart failure teams, and the key thing is to make sure you get on the right drug classes. The blood pressure is important for sacubitril/valsartan. We don't see blood pressure problems with SGLT2 inhibitors or MRAs, but we do see sometimes blood pressure reduction with sacubitril/valsartan. It's not a problem if somebody's blood pressure is over 100 systolic. We never go with sacubitril/valsartan if somebody has a blood pressure systolic in the 80s. I don't use sacubitril/valsartan in those patients. If it's a high 90s or over 100, for sure. There's a kind of gray zone between 90 and 95. Michael, did you agree with that, or what's your tips?
I absolutely agree. Personally, we are not very concerned So what you are concerned of is acute kidney injury, so acute kidney failure, right? And the problem is, or not the problem, the good thing is when we do meta-analyze all the trials by SGLT2 inhibitors, there is a reduction of acute kidney injuries. Some physicians are always afraid when they hear there is sodium excretion, of course, filtration pressure drops, and then of course there is acute kidney injury, but that is not the case. In all the heart failure trials, acute kidney failure are reduced by 30% in meta-analyses. So therefore, we are not very afraid to give it together, but there is no need to give it together, right? You can separate it by 1 or 2 or 3 days. Then you have time to control kidney function, right? But starting early, and as Mark Petrie has said, leaving the patient out of the hospital on the 2 drugs, I think that is of key importance.
All right, there are a few questions. We may have to skip through one, but here's one. Maybe this is for anybody, really. If a patient has urinary tract infection and diabetes, can we add IMPA tablets at that stage? Diabetic UTI, can you add IMPA?
Yeah. Okay, so I think the key thing for the participants is to separate genital tract infections from urinary tract infections. Genital tract infections are increased by SGLT2 inhibitors, and I spoke about that during my talk. Urinary tract infections have not been increased by SGLT2 inhibitors in most of the trials. So the 2 HFrEF trials, there was no increase in urinary tract infections, and there was none in DELIVER. In Emperor Preserve, there was a very, very slight numerical increase in urinary tract infections. So my clinical practice is I wouldn't actually start an SGLT2 inhibitor during a urinary tract infection, but I would be starting one soon after resolution. They don't increase urinary tract infections like they increase genital tract infections. So I'm pretty relaxed as somebody with UTIs.
I agree with you. I think that's a rational advice. There's a question here. Any ongoing trials for cardiovascular from all antidiabetics like sulfonylurea? I would say no, unless anybody knows. I don't think we'll see that. The other question is, this is a very broad question. The contraindication to SGLT2 inhibitors, absolute contraindications. Do you want to address that, Michael? Contraindication to SGLT2 inhibitor. There must be, there are some, but absolute ones.
Absolute contraindications, I wouldn't say that. I mean, type 1 diabetes, we have no data at all. There could be a higher rate of ketoacidosis, and therefore it is not used. It's not indicated in my country. It's not approved. So therefore, we would not go for type 1 diabetes. The other thing is, if there is a history of ketoacidosis and this is not resolved why that was, one should be cautious, but absolute contraindications, no, I would say. If there is indication, the benefit is greater than the risk because well tolerated and it's reducing outcomes in all of these 3 areas.
So I'm going to skip through questions. There are a lot of questions there, sir. Is there any benefit from increasing the dose of IMPA from, say, 10 to 25 in patients with heart failure?
I wouldn't say no, because we have the EMPEREC outcome study. There is no dose relationship between the 2 doses which are available on the market concerning outcomes. Some diabetologists use it in strongly obese patients with a high level of glucose, right? In order to follow the idea that there is more glucose excretion, which is certainly true. So if somebody is coming from a diabetologist, I would not get off the drug and reduce the dose. But I think for outcome, there is no indication to use the higher dose compared to the lower dose because the Kaplan-Meier curve in that trial, they're really superimposable. Mark, do you agree?
Yes, that's the only trial that had 25 milligrams in the trial. So you're right, EMPEREC outcome was the only trial. I agree entirely.
Yeah. So another question is the use of SGLT2 inhibitors in a pregnancy if they have heart failure. If they have heart failure, tough one. Do you want to address that, Mark?
Yeah. So there's no safety data for SGLT2 inhibitors during pregnancy. So in our practice, we don't use them during pregnancy. We start them after pregnancy. There's obviously a debate about whether to use them during breastfeeding as well. And what we do is we discuss that with our patients afterwards, and we have a discussion. There's no clear data to guide us. So during pregnancy, we only use diuretics and beta blockers. That's what we do during pregnancy. So it's difficult. Pregnancy and management of heart failure is very challenging, and Michael and me have collaborated on this for some time. We have actually published a manuscript detailing what drugs you can use during pregnancy and during breastfeeding with a green light, amber light, and red light, different coding. So I would encourage people to look at that when they're managing people with pregnancy and heart failure. It was in the European Journal of Heart Failure 3 years ago, and we were authors of that.
Yeah, there's a question which is not well articulated. Can hypothyroidism be treated and stop medication? I don't know exactly what is meant here by that question. If any of our speakers can decipher the meaning, otherwise we can go to the following question.
I don't think you want me or Michael's opinions about thyroid management. I don't think.
Yeah, I don't think
the question is quite unclear. Hypothyroidism should be treated, and one could speculate heart failure and hypothyroidism, mixed edematous patients, and then when that is resolved, can we stop the drug? I don't think so. One should at least leave the drug in until the heart failure is resolved, if that is meant by these questions, but I'm not sure.
Okay, so what is the definition of prolonged fasting? How many hours? I think in one of the talks there was, do you want to take it?
Yeah, so in my mind, if somebody comes in for a day case procedure and they're fasting in the morning, I wouldn't be stopping SGLT2 inhibitors. If somebody's fasting for more than 24 hours, then I would stop the drugs. That's our routine rule of thumb. I don't know if you agree, Michael. What's your threshold for stopping during fasting?
Yeah, absolutely. If there is a procedure, an operation, it should be stopped, definitely. But I was just in Saudi Arabia, and the question was, what about Ramadan, right? And so that question was asked, and when you break fast in the evening, then it can be taken. Yeah, you switch it from the morning to the evening. That was a recommendation given by a diabetologist, and I find it okay. I find it very reasonable.
That's right. Yeah, I think there are quite a couple of studies testing to their safety use in Ramadan. Absolutely. Ramadan, yeah, okay. IMPA kidney trial. Any hypothesis why the benefits did not extend to patients with mild albuminuria? I know this is not something that you address, but maybe Michael can address this. Mild albuminuria benefits of SGLT2 or lack of it or less of it with mild albuminuria.
That is right. So the EMPA kidney, when randomized, and then they of course ended up with very low risk patients, right? And what I've said in my talk, albuminuria gives the speed of kidney decline. And when you then have low-grade microalbuminuria, the speed is low. And that is my interpretation, Mark. I would be interested to see what you are thinking. So when the speed of declining of kidney outcomes is low because albuminuria is low, then of course the observational period in the trial duration is not sufficient to detect the adequate effect. So the higher the risk, the less patients you need. So therefore, I think this is just a technical thing coming from the trial design. So in high-risk patients, you have it easier in 1 or 2 years to show a benefit. So I don't think that they do not benefit because mechanism is mechanism, and also maybe albuminuria when you have the appropriate risk factors like uncontrolled hypertension whatsoever is increasing over time. They might benefit, but it cannot be observed in a trial with a limited duration. Mark, what do you think?
Yeah, I think you're exactly right. It's a bit like DAPA-MI, Michael. If you've got a low-risk
Yeah,
patient,
exactly.
you can't reduce events if you don't have events in that subpopulation. So
Exactly.
if you had more patients in that subgroup and followed them for longer, I think Michael's exactly right. So basically, it's lack of power in that group. So it's not a lack of effect. It's a trial not designed to show benefit in that group.
All right, great. The second question would be, any differences between DAPA and IMPA in their efficacy, I assume, in relation to heart failure here or CKD? You want to take it, Mark?
Yeah, so this is a very common question, and I think the truth is that we've seen very, very similar results with empagliflozin and empagliflozin across all of the different indications. So on the basis of slightly different trial designs, and an example is EMPA-KIDNEY and DAPA-CKD, or EMPA-REG and DECLARE, or EMPA-REDUCE and DAPA-HF, we've seen slightly different results, but that's a reflection of the patient population and the trial design rather than the drug. So I think almost everybody in the world is convinced that SGLT2 inhibitors are excellent drug therapies, but I don't think you can separate the drugs in terms of the drug classes. There's a drug class. The drugs themselves are almost interchangeable. And we've seen this, and we've seen arguments between different people about slightly different findings in different trials. But I think over the ups and downs of the diabetes trials, the HFrEF trials, the HFpEF trials, the kidney trials, and the hospitalized trials, we eventually have come to realize that they're almost interchangeable. Michael, do you agree or disagree?
Absolutely. This is more a technical question. Everybody is asking when there are two drugs from the same class, provide some results. All meta-analyses show that there is no heterogeneity. The rest is trial design. And I would just like to add, there is not even a reason to believe that there is a difference. They are very similar drugs acting very specifically on one molecule, which is the SGLT2 inhibitors. The affinity to that is the same. The dose applied concerning pharmacokinetics is very similar. It's a once-day dose in both cases, so there are not even theoretical reasons to believe that there is a difference.
Great. Let's skip the two questions because we have addressed them more or less earlier and go to the patient with HFpEF. Is it beneficial to add it from the start and patients with CAD and normal ejection fraction, or those with high risk for CAD but without objective evidence? It's a big question, but I guess the first part of it, is it beneficial to add it from the start? And I think you have alluded to that earlier, Mark, so maybe you can just reiterate.
Sure. So we do see benefits in HFpEF regardless of whether people have coronary artery disease or no coronary artery disease. So we recommend starting it early because of the early benefit. I think it's a very interesting question because coronary artery disease is extraordinarily common in HFpEF. If you do observational series and look systematically for coronary artery disease in HFpEF, just about everybody has either epicardial disease or microvascular disease. So it's a really fundamental part of the HFpEF syndrome. There's lots of theories as well about how much HFpEF and the microvascular disease in HFpEF is relevant from a point of view of the pathophysiology of HFpEF. But from an SGLT2 inhibitor perspective, the treatment is effective regardless of the presence or absence of manifest coronary artery disease, let's put it that way, because just about everybody has coronary artery disease.
Okay. Would you recommend, let's put SGLT2 inhibitors, it says DAPA for all post-MI cases with no DM? Michael, do you want to take that question?
Yeah, that is There is this, first of all, obviously, no, all is a big word, so that is always, the answer is always no, yeah. But the interesting question is you have a big MI and you have impaired left ventricular function. So when is it a post-MI patient and when is it a heart failure patient, right? So that is the same question in the AIR study with ramipril, it's a valiant study. So when does heart failure starts and when is the post-MI thing over? So that is an open question. So we have mentioned, or Professor Petrie mentioned DAPA-MI without benefit. Sure, but it has, of course, also safety, yeah? So I would, if there is impaired left ventricular function and symptoms of heart failure, I would start early, but I would declare this as a heart failure treatment rather than a post-MI treatment. I would not, maybe it's not necessary to start a couple of hours or immediately after an MI, but so it is safe. So then all of a sudden it is heart failure, and then one should not come too late. Yeah. That would be my take on it. But my question, maybe you can answer, somebody can answer it for me. What is a post-MI patient and what is an early heart failure patient? There is no diabetes, there is normal pump function, no signs and symptoms of heart failure. The answer is no.
Yeah, I think the DAPA-MI trial was interesting for several aspects. One is, I think, people were concerned about starting SGLT2 inhibitors in the context of myocardial infarction, where somebody's just had PCI, has had contrast, and maybe been started on a beta blocker, an ACE inhibitor, an MRA, and then adding an SGLT2 inhibitor. So the safety aspect of DAPA-MI is interesting. So I think if somebody has an indication for an SGLT2 inhibitor, so if they have diabetes or if they have renal disease, then DAPA-MI was reassuring from that perspective. The problem with DAPA-MI was, as we've discussed with EMPA kidney, they chose a very low-risk population. So they intended to show a reduction in the composite of death and hospitalization for heart failure. But that wasn't possible because the event rate was very, very, very low. They allowed everybody in with any wall motion abnormality on their echo. So you could have any MI essentially. So the trial didn't do what it intended to do and ended up showing some metabolic benefits. So I think it's not persuasive to most cardiologists to start all people post-MI, but we do have the impact MI, which will be presented in April at the Medical Cardiology, and that is a heart failure population enriched for heart failure risk. So everybody had to have a risk factor as well as having a low ejection fraction, less than 45%, or congestion requiring therapy. So impact MI is a big deal, and that will inform the prescription of these drugs following myocardial infarction, and we don't have to wait too long to see the results of that.
Okay, great. So the question is about type 1 and use of SGLT2 inhibitors, and I assume the question relates to type 1 with heart failure or CKD, because this is our topic here. So maybe Mark, can you address the use SGLT2 inhibitor type 1 with heart failure, and I guess are there any studies there?
So first of all, the clinical take home is, in my personal opinion, is that cardiologists should not be starting SGLT2 inhibitors in people with type 1 diabetes. So what I do, if I have a type 1 patient who I think might benefit, is I pick the telephone up and I speak to my endocrinology colleagues, and I leave the decision and the management entirely up to them. Sometimes they do start SGLT2 inhibitors in people with type 1 diabetes, but they do it with close ketone monitoring. And that's not something that cardiologists do every day. So for me, I will only do that if the diabetologist is managing the patient. Is there a trial? There are no completed trials. There is a trial which is ongoing called SOPHIST, which is a sotagliflozin trial in people with heart failure and type 1 diabetes. That's been highly scrutinized and has been very carefully conducted. including lots of ketone monitoring during the trial. So that is ongoing. It's a small trial, and it will not report for 3 or 4 years. But I would encourage cardiologists not to try and manage type 1 diabetes. That's my personal opinion. And I don't know, what Michael, are you a type 1 diabetes management expert or not?
No. If there is a necessity to do so, then it should be done by the diabetologist. I have never seen a patient, not even from a diabetologist, who got it. In Germany, or I think in Europe, dapagliflozin has withdrawn their approval for class 1 diabetics, because of course the risk is higher, and I don't think it makes sense. Type 1 diabetes, I mean, has different treatment options, right?
Okay, let me skip through some of the questions and go straight to this question. Is there a benefit from reducing epicardial and pericardial fats with SGLT2 inhibitors? Who wants to take that question?
There are interesting hypotheses that this epicardial fat is very metabolically active, number one. The second hypothesis is that these cytokines, pro-inflammatory cytokines, are draining directly to the heart and have a poor outcome in heart failure. These are also associations, and SGLT2 inhibitors reduce it, right? So these are the three findings. To create causality in between them is not proven, is not proven. However, it's an interesting hypothesis.
Yeah, but I can't resist contributing, because again, exactly, Michael summarized it as usual perfectly. It's an interesting hypothesis, and we've heard lots of hypotheses about inflammation in heart failure, and there's a big feeling that nobody will know.
All right, great, thank you. Here is another question relating to the use of SGLT2 IMPA and CKD grade 4, 5, stage 4 or 5. Michael, do you want to take that question?
I think we already had it. We had it. So I would also go along with Mark to say, okay, we can use it below 20 if there's no sodium excretion anymore, because people are on dialysis. We have no data. We usually don't do it, but that does not exclude that it might have some effects, but we have no data on it.
All right, well, we certainly have a lot of questions, and we're coming towards the end of this webinar. And at this point, I'd like to thank our speakers for their fantastic contribution and answering all those difficult questions, and also thank our audience from across Africa, Middle East, and India for being very active participants. And of course, thanks for the organizer and the sponsors of this webinar. It's been a great session. I've learned a lot and I've enjoyed it. And I hope that we'll meet again in such setting. Thank you very much, Michael and Mark, for your contribution. Great.
Thank you. Bye-bye.
Great, good fun. Bye-bye.